Well, it's that time. It is Monday night, and we are with the Fab Four -1. Right now, we're working on a little technical issue that we're going to get resolved here in just a few minutes, hopefully. Good evening. I'm Scott Mitchell. That's Dr. John Armitage, MD, the CEO of OBI, which people have been asking. I've been seeing a lot of Dr. Armitage this week. Dr. Chansolme, MD, Chief of Infection Prevention for Integris. People have said, I've seen a lot of Dr. Chansolme this week. And Dr. Sublett, which over the last 2-3 weeks, people are saying, I've seen a lot of Dr. Sublett this past week. Good to have you on, the president of the American Academy of Pediatrics here in Oklahoma. Our fearless leader is somewhere right now trying to work through some technical challenges, which happens every week, because it's live. And good to have you with us. And I'm going to jump in really quickly because our friend COVID-19 in Oklahoma said, I want the first question this week, which is about boosters. I've been getting emails from Dr. Armitage talking about messaging, and you couldn't sit down and plan how to screw up messaging more than what we've seen in the last 8 or 9 days. And frankly, some folks in the media have helped with that. I mean, frankly. We also are going to be talking about monoclonal antibodies, a perceived shortage. Lots of stories about that became very, very high profile. And then, of course, the things that are happening in OBI. So let me just start, Dr. Chansolme, the first question, Dr. Sublett, Dr. Armitage, which is, okay, folks, can you help us understand precisely who, when, where, why? Who are the first people that need to get boosters?
Me. No. So, the data, you're right. The messaging has been poor. And that's unfortunately something that we've learned to navigate throughout this epidemic is how to parse through what they're actually saying. The booster stuff came out of Israel originally, looking at whether or not there was some value in having people boosted. And to their credit, the FDA and the CDC and the ACIP and all of these other organizations that look at vaccinations really tried to take a very hard look at the science. The problem is time doesn't really allow for us to be able to collect as much science as we would like on this, and it doesn't allow for us to parse through it as well as we would like. So I think there are some places that are pretty simple about who needs a booster. I think primarily it's going to be those people who are over the age of 65 and people with pretty profound immunocompromise. The original booster data came out of the solid organ transplant patients, so people with a heart transplant, lung transplant, kidney transplant, liver transplant. There was some pretty good data at the very beginning, I think out of Hopkins, that showed they had some increase in their antibody levels with boosters. Now, whether or not that really parlayed into how much less disease they had or not wasn't very clear. But that was the first group, as you recall, that they were boosting after 30 days after their second dose of Pfizer or Moderna. And there was some data there that showed that might have helped. More and more started to pile on. And what we started seeing in the hospitals was we would see some people, and I cannot stress this enough, this is a pandemic of the unvaccinated at this point in time. That cannot be overstated. And I know people are sick and tired of hearing that. It just is true. Over 90% of our patients in the hospital are unvaccinated. There are some people that are vaccinated, and those tend to be older people who were vaccinated at the very beginning. Remember, the first people that got this vaccine were in December and January and February. So we were seeing some of those, and some of that early data coming out of Israel showed that. I think where it really started to get difficult is when they started talking about frontline workers and people who are at high risk of catching COVID because of their occupation. And it seems like that was where it got bogged down. You got to remember, even though the original vote recommended against boosters, it only recommended against boosters for that group of 18 to 64-year-olds who are otherwise healthy and who are at high risk based on their profession. Some of the other groups were, everybody voted in favor of 50 to 64 with a high-risk medical condition, over the age of 65. Those groups went through. So it's just important to ask your doctor or to show up at one of these places where you can get a booster and see if you're eligible for it. That being said, I'm still not convinced myself of what we know about what a booster means. I've had people come in and say, my antibody levels are low. I got my blood checked, and I say to them, I don't even know what that means, and I'm pretty sure I would know what it meant before you would. So I don't even know what that means, because cell-mediated immunity is not easily measured. I mean, there's so many nuances that go into it. But talk to your doctor if you think that you might be a candidate for a booster, because you very well may be. So that I'll start it off there, and then we can bash everybody about the way they messaged this if you want to.
Yeah, and I would just add that the data around younger folks having access and getting a booster, chances are a booster's not going to hurt somebody who didn't have a reaction to the first 2 shots. I mean, in the do no harm category, it's hard to imagine a lot of harm coming from a booster. I have heard that some of the symptoms are worse on the 3rd exposure, but we're trying to drop the booster doses. I believe that's part of the research that's going on to maybe do a half dose or whatever as a kind of a memory stimulus in the immune system. So, if you're really concerned and you're less than 65 and you don't have those other health concerns, this is a little bit like the folks who signed up for the experimental vaccines originally. Jump in there. Be part of the data gathering. Make yourself feel like you're helping by gathering data, gathering outcomes. Hopefully it works, but it's probably not going to harm many people. But again, it's pretty soft. The thing that I guess frustrates me on the communication is we've still got to remember the primary. You started with it, David. It's unvaccinated. It's nothing to do with the boosters that is really affecting the trajectory of our experience of the pandemic or our escape velocity from the pandemic. So that's really, maybe the saddest point about this whole booster conversation, is because it's been miscommunicated. It becomes more of a story. It sucks up more oxygen trying to figure out what they want to say, and we're losing the thread. Dial it back. We need to be unvaccinated to get vaccinated. So,
yeah, I would agree.
And we also need better data, I would say, on the natural immunity. I still think that it is not helpful for us to leave that piece of this conversation on the sidelines. Getting mandates now, and I don't want to jump ahead because we probably have a lot to say about boosters still, but the idea that the mandate for vaccination applies equally to the non-previously infected and the previously infected, I don't think we should be having the conversation at least about why people think those 2 categories are the same, because everything I learned in biology says those aren't the same people when it comes to protection. So.
That's a good point. I agree with what's been said. I think that the boosters probably don't hurt anything, but we still got a long ways to go to get this unvaccinated crowd going.
So the reason they didn't approve the 18 to 49-year-old was because of a very small risk of myocarditis that you can have, a very reversible issue. Goes away. It's self-limited, but I mean, that's a real thing. Myocarditis means an inflammation of the heart muscle, and it's very rarely something that even anybody is hospitalized for. But what they said was, in an 18 to 49-year-old who's perfectly healthy, and perfectly healthy means perfectly healthy, things that would put you in the category of qualifying for a booster, like diabetes or something like that. There's a lot of 18 to 49-year-olds that have that. So that's not including those folks. The perfectly healthy 18 to 49-year-old, they said was they felt that the very small risk of myocarditis might be equivalent to the risk of hospitalization at that age for somebody who is already fully vaccinated. And I think there's a valid point there. If you've already had your primary series, what more bang for your buck are you getting if you're a perfectly healthy 18 to 49-year-old? Now, where we have seen value in it, the places, the 50 to 64 with health conditions, or the over 65 and other people, that those ones, there's still risk of hospitalization, things of that nature there. That doesn't mean an 18 to 49-year-old. I mean, my son is 19 years old. He had COVID a couple of weeks ago when he went to college, and and he's fully vaccinated. He felt like crud for 3 days. He really did. He, even then, he's a perfectly healthy, he's a runner. I mean, he's a perfectly healthy kid, but he still felt like crud. So it doesn't mean you won't feel like crud, but I don't necessarily know. It failed by a vote of 9-6. It's not like it was an overwhelming slam dunk. It was more like a last minute field goal. Too soon?
Oh, we love those.
How many yards?
Field goal.
30 or so?
And I think they just need a little bit more information before they bring in the backup quarterback. That's all I'm saying.
The other thing, when we talk about the communication, this was another opportunity to let the public, in on, the trade-offs, right? So if we were talking about the risks and making decisions and allowing the public, the healthy public, to make their call on whether they get this booster under age 65 or under age 49, publish the compare and contrast by age. What is your risk of bad outcomes if you're 30 and healthy? What are your chances of myocarditis versus your chances of ICU? Give us the data in a digestible format. Don't say, oh, you can go look it up. You probably can't. And even if you can, who has the time? Nobody. Right. So give us adult type information about something. In this case, it shouldn't have a lot of political overlay on boosters. Again, the major drive should be on the primary vaccination. Mm-hmm. So just put this aside, treat us like adults, let us see the data and make our own assessment.
Exactly.
Do I feel nervous enough to take the risk of myocarditis? Okay, take it. Again, it's so frustrating to have this partial information denies us the chance to really grapple with our personal perspective on the decisions, as well as what we should be doing as a policy making group, a democracy.
But from what I've read on this myocarditis thing, vaccine induced, it tends to be mild. It tends to be self-limited, about an 8-week ordeal. And the way I look at it is, okay, you don't get the vaccine, you get the real deal. You're going to get an inflammatory response, not only in your heart, but all over.
Oh, yeah. Yeah.
And I just don't see that. That's a risk there. But it's more prevalent, as I understand, maybe it's changed, in our older adolescent, younger adult population, which do tend to be healthier. So I just don't see that as a major.
I think the number, to answer that question, John, for our viewing audience, I believe the number was the risk of myocarditis was like 4 per million in women in that age group, and maybe 16 per million in males in that age group. So still really, really low. But I can tell you, having been on the wards forever now, and if those numbers are wrong, I apologize. But I feel like that's what I saw in kind of the FDA advisory committee's reason why they didn't approve it. But the risk of like Dwight said, systemic inflammation, including myocarditis, which is an inflammation of the heart, is very high in people who are hospitalized. 30, 40, 50%. All of them have some systemic inflammation. The magnitude of the myocarditis varies, but it's not uncommon to see people with elevated troponins in the hospital. We see it frequently, and it's not because they're having a heart attack; it's because they have myocarditis.
Yeah, and I guess I would say that thank you for sharing those numbers. Those numbers are hard for most people to grapple with. We don't do very well with tiny numbers cognitively. I don't think. But putting that into perspective, again, if I were Fauci in my dreams, I would be putting out the, what does that relate to the risk of a flu vaccine that most people take like a booster every year? They'll get another shot. So that seems to be an acceptable way for a lot of folks who are in healthcare and other high-risk settings to proceed. So how does this compare? The risk of myocarditis is as likely as a inflammatory risk from flu or tetanus. People get boosted on tetanus. We've got to have comparative information off of which to judge some of this stuff. And again, if you don't do the extra communication to give people that frame of reference, they're going to struggle. They're going to get frustrated, and they're going to take bad information on board because they're grappling for a framework.
If you don't give them good information, they're going to find misinformation, right, John?
Absolutely.
I mean, we've seen that time and time again. Yeah. And even maybe, I don't want to say more importantly, but just as importantly is messaging the good information in an appropriate, digestible format. I couldn't agree more, which is what certainly a lot of those entities could use a refresher course on.
Yeah. And in their defense, I think a lot of the people who are doing the primary basic research on this, that it's okay for them to come up with the 16 in a million or the 4 in a million. The epidemiologists aren't trained to be communicators. So, okay, that's not your job, but please somebody interdigitate yourself into this, intermediate and turn this into communication from just being data and research findings. Please somebody be hired at the CDC and elsewhere to translate this for the American public. I had a great conversation with some of our staff today, and they seemed really appreciative to go back to the basics of monoclonal antibodies and what do they do. Adult learners need to hear stuff not only clearly, they have to hear it multiple times. So don't be afraid of over communicating in kind of basic building block type communications. But we seem to just be a megaphone without anybody kind of putting together the script. Please put together the well-reasoned communication plan and deliver it. Multiple channels, multiple outlets, right? Some people are visual learners. Some people are, they like the written word. Hey, overload it, but don't do it in a way that's not understandable. There've got to be communication experts out there who know how. And if we don't have them, we ought to go train them up. Somebody needs to be able to talk to the American public about complex topics in a reasonable fashion.
Hey, do you guys ever, when you're in situations with your various associations, organizations, or talking to the feds, do you ever say to them, man, your communication stinks? And you were saying these are complex subjects, but I got to tell you, in my end of the business, it's actually pretty simple. Remember, I've referenced it all the time with this shower scene in Bull Durham. Okay. So hit the ball, catch the ball, throw the ball. So, Friday, you go back a week ago Friday. This is a good example. So the what was that first commission that met, which is the one that gives the advice or whatever, the
ACIP.
So the ACIP meets on Friday.
Yeah.
First off, why are they doing meeting on Friday? Number one, because that's when Bill Clinton dumped all the bad information. So Friday, you don't do it on Friday. Number one. So again, throw the ball, catch the ball, hit the ball. That's number one. Number two is they decided to do the general boosters Friday afternoon. Number one. So that story is what everybody's waiting on. So the entire world sees it. It's around the world. And so the advice later in the day on Friday about 65 plus was lost. I mean, they didn't get around to meeting on that till late in the day. Do you recall that? Okay.
Yeah.
Oh, yeah.
So by the time the Saturday press is rolling and then the social media is going, they've lost number two. The 65 plus it doesn't start showing up until Saturday, Sunday late. All right. So I didn't know this. I'm just a novice. I'm with you guys on Monday nights, but so that was just the recommendation. So later FDA and CDC and all these people, they start undoing what the recommendations were. But what they need to be doing is, here's what we did on Monday. Now, here's what we're doing today. They just come at everything is like a brand new world. They just stepped off of the spaceship from Mars, and they don't give context and perspective of what they have done. That's why their communication stinks. There's nobody in charge of, let's recall where we were at on Friday. They don't do that. And I'm just wondering, and by the way, it's not just feds. I see doctors, organizations, things like this do the very same thing. I mean, people are busy. They have other things going on in life. So assume that they didn't see everything that happened a week ago Friday. Assume that you need to say, I mean, sometimes television does it, which gets kind of old, but they'll say, you may recall that this happened a couple of weeks ago. So they're resetting people's perspective or context, or if they missed it. My question to you is, do you ever get a chance to talk to the feds and just go, hey man, you remember the scene in there was a movie, the Brockovich movie, and they have that one scene where she says, "Do they teach you guys manners in law school? Because if they did, you suck," right? Okay? And the thing is that's the sort of thing that happens. They just are terrible with the way they communicate. And I'm wondering if you ever get a chance to tell them.
Well, it's been frustrating in the pediatric world. I mean, we've been sitting with them, going, when are you going to get the vaccine out for the elementary? And well, it is coming someday. It's just very, nebulous. They finally, I think, have come out now. They're targeting Halloween around there, but it's just you don't know what to tell folks. It isn't straightforward at all.
Well, I think part of it's difficult because this is really complicated stuff, and to be able to message something, you have to understand it first. If I'm going to regurgitate something that I understand to somebody else, I have to understand it to be able to rephrase it, right? Mm-hmm. If I don't rephrase it, or if I don't understand it, then I can't give people the information in a readily digestible format, because I don't even know what I'm talking about. I think a lot of times with a lot of these places, this is really, really complicated science. And that's why you need somebody who's a communicator who almost is a dual degree, right? Somebody that's got a degree in journalism or strategic communications or mass communications, as well as, quite frankly, a medical degree. Mm-hmm. And that is not an easy person to find. Now, I think all of the entities you're talking about, Scott, the feds, they all have communications departments, right? I mean, who's the person you see most from the White House? It's Jen Psaki. Mm-hmm. And, the state has a communications officer. The city has a communications officer. But they need to have the information handed to them in a way from somebody who understands what they're talking about and then regurgitates it to them, and then they figure out how to communicate it. And I think that's where the CDC is missing. I think Dr. Walensky is very smart. I do not think she's a very good communicator. I don't think Dr. Redfield was a very good communicator before him. I thought the lady several years ago, Dr. Gerberding, I believe, she was very good. Dr. Julie Gerberding was very good at the CDC at being able to make people understand some of these different things. But I think that's probably, a very small niche person that would be able to do that. And there just aren't a ton of those kinds of folks out there. Dr. Fauci, I know is John's favorite. I think he's probably about as close as we can get. I mean, I watch guys like Z-Dog. I think Z-Dog is really good. He does a podcast, and he's just kind of a doctor who sort of talks. He talks a little too much, I think, but he tries to make it kind of shareable. And we just, but the onus is on those places to make it exactly that thing. It's not our problem not to understand what they don't understand what they're telling us. That's not our fault.
Yeah. I would, agree that much like on last week's podcast, I think I said something along the lines, if you weren't a biologist before COVID, you're not a biologist now. And if your highest level of classwork was intro bio in college, you're not a biologist. And if the only biology you know is COVID, then you're probably not a biologist. And you shouldn't go to the microphone. I would say the same holds for the experts who are being pulled in. If you weren't a communicator before COVID, chances are you're not a communicator now. And you should find one and partner with that person, because the right person, one of the reasons I think our little show here has some longevity to it is we don't always speak scientific, I don't think. And we put some human elements of emotion and caring and trying to get the message across, and people respond, I think, okay to that. But a good communication team would involve an expert and somebody who can pull that out, somebody who can work with that person, translate their immense knowledge and their updates that they want to communicate, and help them turn it into language that people can focus on for a few minutes and not get lost on the third sentence. So again, I would suggest that if you're being asked to speak about this, if this is the first time you've ever been on the microphone or ever been in a leadership role, think about getting some help, some coaching, or at least ask around, how am I doing on the communication piece? Because most of the people you're talking to are your scientific friends who think it's great that you got to the microphone. Hey, congratulations, Fauci. I see you, even though you're 80, you finally made it to the big leagues. Congratulations. You buy the blue light specials for us all.
Oh my gosh, that's awful. Julie makes a great point on the comments here. She says, speak to your audience. And I think that's absolutely right. What I would say to kind of follow up on that is you need more than one line of communication. The line of communication you're using for those folks at the blue light special is not the same line of communication you're using for those folks at the bar that are 20 years old versus 80 years old. So you got to communicate more than one lane, and that the line of communication you use for the vaccine enthusiastic is not the same line of communication you use for the vaccine hesitant or the vaccine complacent. I mean, there have to be more than one communications, and you have to be pretty good at delivering that message, or else it's going to get parsed the way people want to hear it. That which my dad used to always say, and I know I've said it on here, that which is well expressed is well understood, and we have just never really kind of grasped that in the scientific community. For a lot of years, we've just been able to say because I say so. Right? I mean,
those days are over.
Listen to me.
Yeah.
Well, it doesn't work like that anymore. That's all there is to it. It's different now.
Especially under 35 crowd.
Yeah, exactly.
You don't communicate with them in the same sort of way. And if you can't get I
think there's also a responsibility a little bit out on the media to try and help these people, right? Professionals such as you, Scott, you can see the problems going on. Somebody throw these people a lifeline, some professional association, offer up some help to the CDC, please. Let them borrow a communicator for a week and see how it helps them.
If I were to go to the CDC, I would throw balls and bats in the shower.
And that's probably the love language. They'd like that.
Yeah. It's a really simple game. You throw the ball. It's not that hard to do. The problem is that, and I've worked with doctors groups over the years. I mean, they'll absolutely be convinced they're doing a good job when every single human being in the room knows that their stuff is no good, that they're not reaching the sort of thing. And the biggest problem is CDC and FDA, they can't even communicate with you guys. Okay. So how are you going to take that base information and then put it into channels for different genres? For example, Gen Z and folks like millennials, they don't respond to the same sort of stuff. So if you've got a messed up base understanding or base information, how are you going to parse that into some other sort of channel on Instagram, for example, if the information you've sent out in the first place is not? I mean, the thing that's driven me crazy over the past few weeks or the past few days is watching this booster information. It's absolutely like one of those old World Wrestling Federation battle royals, people flying out of the ring. I mean, there's absolutely no context perspective. A new reporter comes in, here's what happened today. Well, they don't, and I'm talking about the media on this one, but they're not taking into context the day before or what was said the day before that. There's never been context. It's all about this moment, this space shot, or this screenshot, and some of it is a space shot. And then you've lost people. I mean, there has been at least 4 or 5
Scott, that's the way people understand things nowadays too. They don't want it. I mean, how many people read? I mean, I'm sure you guys have this data, Scott, from websites and things like that. How many people read a 5-page article in a newspaper anymore?
No.
They read 3 paragraphs. I mean, people want sound bites, clips. Again, the science of communication is knowing how to communicate the message you want to in the appropriate medium to the appropriate target. And that's where we need some help. But it's complicated science. The papers I read are 30 pages long. I mean, you can't get that out in a tweet. It's hard to get out in a tweet.
Well, I do think one of the self-inflicted wounds here is that we have multiple spokespeople trying to interpret. You got the CDC, you've got NIH, you've got a lot of different entities trying to contribute. I think they all want to help the situation, but at the end, we'd probably be better off with one official spokesperson and take a panel. They take inputs from all the agencies and they speak with one voice because they are one voice. This last week has been just a travesty of people talking past themselves in the same government.
Mm-hmm.
I said one thing, I changed it, and round of applause or big raspberries because somebody stepped forward and revised the guidance. It doesn't play well, and it could be solved, right? We could have a communication. We could have the Psaki, let her off of the COVID story and have a special press agent or press secretary for COVID. It's that important. Yeah. We probably deserve that kind of position dedicated to it because we're clearly flapping around now, and we have been for a long time. One of the things that's amazing is really good government, responsive government. You don't expect your government to get everything right the first time, but you do expect them to work and improve over time, and this is not showing. When we talk about monoclonals, to be in a shortage situation, it's just remarkable that after Operation Warp Speed, one of our few successes was getting lots of vaccine available as quickly as possible. We opened up lots of tests and then whittled it down to just a few that were really good. We've done a better job earlier on production. So again, let's get better at this pandemic over time. Let's not go backwards, and let's adapt.
That's a good point.
Americans can believe in a government that slowly gets better. I don't think we believe in something that's static or moving backwards. That's not what we're used to.
Yeah.
So that may be a good point to shift to messaging about monoclonals. So this is more Oklahoma, and you guys all know I've sent you the information that I started getting questions. So News 9 did a couple of stories last week, one with the governor, one featuring my friend, the floor leader in the House, John Echols, about shortage of monoclonal. Everybody knows that the federals have taken it over. Everybody knows part of the issue has been, I'm going to make sure that I've got the numbers correct, but 7 southern states are 60% of all the monoclonal that's being prescribed. So the governor last week made a trip to an infusion place. John Echols was on with Carl Torp. They were talking about the shortages. And then there was a Oklahoman article, a really good reporter that has come over there to write about medicine over there. And then she quoted that there was a lady with the Oklahoma State Department of Health saying that, it's the level of demand is not lining up with what's being administered. The clear implication was that there's not as much being administered as what's being ordered. And then there was an unknown doctor that said doctors in one of these stories fear that there'll be shortages. I walked away from all three stories being more confused than ever. So let me just see if I can break this down. Do we have enough monoclonal in Oklahoma on September 27th right now for people that need it? That's number one. Number two, is monoclonal being prescribed for people that don't yet need it? I mean, is it being used extra to what it should be being used for? And is there a fear of what's coming? So there were so many questions I have. That's just 3. The first one is, do we have a shortage now? And is it all being used in the way it should be? And are we sitting on piles of extra monoclonal?
We are not sitting on piles of extra monoclonal. Now I can only speak about our experience, but we talk amongst the community. I think there's, if I'm not mistaken, I think there's 130 registered infusion agents that are giving monoclonal antibody around the state. Scott, I thought it was 6 states that were 70%, not 7 states that were 60%. But either way, this is southern states. It was not, Oklahoma was not one of those states from what I remember, and I may be wrong about that.
Oklahoma is not in that list.
Yeah, so I think kind of where it happened was the northeastern states were complaining about not having enough monoclonal antibody for their people. I don't know. I mean, they've done a much better job of vaccinating than we have. The other thing was monoclonals started getting more press. I mean, we've had monoclonals around since October, November, December, somewhere in that neighborhood. But we weren't giving it that many people because not a lot of people knew about it. Everybody knew that Trump had gotten one of the products, but not everybody knew what it was. And not a lot of doctors knew how to give it or prescribe it. You can't just give it in your office. It's not that simple. There's a lot of rules that go into it because it's under an emergency use authorization. I would say it's not being given indiscriminately because those rules are there, which I'm kind of a fan of. I'm not always a fan of the EUA, but I think for the monoclonal antibodies, it's done a pretty good job of making sure that it's given appropriately. As time has gone on, the candidate pool for monoclonal antibodies has widened and widened. At first, it was over the age of 65 or BMI greater than 35 or diabetic. Those are the main three: chronic kidney disease, chronic heart disease, chronic lung disease. But then it widened to over 55, and then it widened to BMI greater than 25. So you just make a bigger cohort. And I think a lot more people, a lot of people were reading about it. They were asking their doctor about it. I got lots of phone calls from doctors saying, how do I give this? And so when the allocation rules came out, we all said, and then we started kind of figuring out, well, how do we manage this resource appropriately and adequately? The good news is, I think requests for monoclonals are going down because cases are going down. So it turns out that the allocation, we may not have a bunch of extra sitting on the shelf, but I think right now the state, and I don't know from anybody at the state or anything like that, but I think right now anybody who wanted a monoclonal could probably get it. Anybody who qualified for a monoclonal could probably get it if your doctor knows enough. Now, there's a lot of things that go into that. You can't get a monoclonal on day 11 after your symptoms. You have to get it in the first few days. So if you get COVID and you say, I'll just wait until I feel worse before I get the monoclonal, well, by then the horse is out of the barn. It doesn't matter. You got to give it early. So there's still some nuances to it, but the allocation system is a little bit scary, but it turns out that I think Oklahoma is doing a pretty good job of managing it right now. That's a really long answer and a really terrible answer. Speaking of communication,
I have a question in that regard. Today I was listening, and this came up about the shortage. And one thing that was brought up is that monoclonal has been used in individuals who have simply been exposed. Their test is not converted to positive, but they've gone in and received the monoclonal. Is that happening?
There is a carve out in the EUA for certain people who have been who are high risk exposures. So if you are a patient, say for example a lung transplant patient, and you came into contact with somebody who had COVID, then you might be a candidate for it. The caveat there is only people who are unvaccinated would be a candidate. So a vaccinated person with a high risk exposure would not be a candidate for the monoclonal antibody. What's the message there? Get the vaccine, right? Yeah. Now, we have lots of people that have a positive test for COVID who have gotten monoclonal antibody. But much to my surprise, the vast majority of patients are unvaccinated. So to me, it's just comical that people continue to question the vaccine, but they're more than happy to go get a monoclonal that's less FDA approved than the vaccine is. The vaccine is fully FDA approved, but they'll go get a monoclonal antibody and sit there for 3 hours rather than taking a tiny little needle in the shoulder.
So let me jump in on this one. So that we further the question. So is there anybody in Oklahoma in the past week that wanted monoclonal that didn't get it? And to y'all?
Not what I've heard. I don't know. Not what I've heard. I mean, the biggest rate limiting step for us at the beginning was the same thing it's been. I think, I can't remember if it was the Oklahoman article or a different article I did, but the biggest rate limiting step for us has been the nursing shortage. The monoclonal antibody takes 3 hours to infuse. It requires a skilled nurse to put in. You got to put in an IV. You got to have a pharmacy to mix the drug. That's been the hardest part. You got to have enough chairs to put everybody in. You got to have enough people to monitor for the hour or the hour and a half you're required to monitor somebody after they've gotten the infusion. So when we were having problems giving monoclonal antibodies, it was because chair space, just like we don't have ICU beds. Sometimes there weren't monoclonal chairs, right? Monoclonal is outpatient treatment. I should say that. It's not something we give inpatients. And so that was the rate limiting step. That being said, we still got most patients in within 48 hours of their request, at least at Integris. And I suspect that's been the way it has been around most of the state. I think the biggest things that would have been a difference would have been access based on where you live, and just the ability for whatever space to have enough chairs to do it.
Well, one of the surprising things to me in this conversation about monoclonals, the fact that, you know, we've had these drugs since the beginning of the calendar year under EUA, and to get to a point in the modeling of the virus and its effects and the use, it stuns me. You know, we have actuaries in this country that can do the math and can model out, you know, what a spike in a new variant would do. And the fact that we weren't stockpiling something that's got a pretty long shelf life, as far as I'm aware.
It does.
We weren't at big risk for overshooting this mark, considering, you know, what we were worried about. And again, part of the government's role here is to worst case model and to say, you know, if we save how many ICU beds by stockpiling this and having it available, instead of talking about rationing it or allocating it. I mean, that's a huge story to me, that we were not able to synthesize enough preparatory thinking to protect ourselves. And we had many, many months. And we were screaming. We on this show were talking about people need to know about monoclonals probably not 2 months ago at the beginning of August, right? That was the big story. So somehow we went from nobody's using this stuff and isn't that a shame to, my God, we don't have enough of it in 2 months. That seems like a really bad outcome, you know, considering we asked for it. Essentially, the medical community asked for it, we got it, and now we don't have enough product to handle it.
Part of it was, you know, they pulled half of it off the market, right? Remember, they pulled the bamlanivimab and the adacivimaab. So there's 3 different monoclonals. There's the caricivimab and divimab, which is the Regeneron. There's bamlanivimab, adacivimaab, and then there's the last one was sotrovimab. The BAM-EDI got pulled off because it didn't have as much activity against the alpha variant. It turns out it was pretty good activity against the Delta variant. So that caused a dip, but that wasn't really the problem. I was as mystified by the allocation as everybody. I was like, oh, I didn't know we were running so low. I guess, okay, I'm sorry Oklahoma's maybe gobbling up more than they should, because you never really heard, even before they did the allocation, it's not like you saw all these news stories coming out of Delaware about all the poor New Englanders who couldn't get their monoclonal antibody. I was like, why all of a sudden is there an allocation? You know, I was and talking with people that are more than know, they're like, yeah, we were a little bit surprised too. That being said, I think the Oklahoma State Department of Health was very upfront with us about what they thought would happen, what they thought the allocations were going to look like, and we started planning really, really, really quick, really early on about what we thought. And at the same time, cases have been dropping, so it hasn't, knock on wood, been as big an issue. I don't know if that won't happen later on. Every week, the allocations are administered on a weekly basis. So every week we find out kind of what we can get. We don't have as much on the shelf waiting, but, you know, well, hopefully we will.
So just on the communication front, wouldn't it be interesting to know what the target level we should be shooting for is and how close we are to having that nationally? Oh, sorry, you're too stupid. You're not allowed that information.
Yeah. No, it's
all right, so that's 3 stories, and I'm more confused than ever. So and I'm just trying to figure out, I know what the governor and John were saying, the feds are getting in there and messing around on this, and I'm reading an Oklahoma story that's kind of going the other way, saying, well, we've got what we need. Basically, the requests are not lining up with what's being distributed, and I'm going, okay, well, I'm not sure what's going on here.
I think it's human nature to maybe order a little bit more than you really needed. And I think every hospital, because of what we've gone through for the last 1.5, 2 years, has wanted to do that. But that being said, right now, I mean, you know, I know we don't personally, I know I don't have any patients that are waiting for the state to deliver their dose. Could that happen at the end of this week? Yeah, they could say Oklahoma doesn't need any. We're going to give it all to Texas. I mean, I don't know, but I don't really understand why the allocation happened in the first place. Hey, you know why the South is ordering 70% of all of it? Because that's where all the daggum COVID is right now. That's it. I mean, it's not going crazy in New Hampshire. It might. You know, they need to be giving more in Idaho. They need to be giving more, obviously, in Alaska. I mean, you know,
that's the really interesting piece to this story is since we're not hearing of patients actually not able to get it because of the production, there may be people who have limited access to nurses and other things. If we're not hearing about patients suffering in Vermont or wherever, then what we're doing is one of two things. We're either creating a perceived shortage that potentially could take the supply from people who need it, where it's being ordered, to people who might need it, which is not a very reasonable way to allocate a medicine. You can't have this because somebody else might need it, even though you need it now. So that would be a really bad thing if that were happening. And if we're not going to see that the shortage impacts patients down the road here, then maybe this was a made up story that distracted us, which is really bad, right? So even if no patient ever goes short in this and the allocations don't strip supply from sick patients, if nobody goes short and the allocation apparently had no impact because it didn't save anything, right? Nobody got shuffled anything that made a difference to having the available supply, then that's distracting us, right? That is almost misinformation, disinformation that took us down a total rat hole, or, you know, and that's bad too. Either one of those two scenarios is really bad.
Yeah.
And how do we get to the bottom of it? Where's the investigative journalism that starts to look at, okay, how many doctors, raise your hand, have had to short, you know, monoclonal treatment? And if the answer is none and stays none, then we've got a significant story.
Well,
But we'll never do that research. Nobody will ever do that.
It'll get put in the back burner with all the other boxes and the Raiders of the Lost Ark warehouse. It'll just be put back there somewhere. Top men are working.
How about this one? So Tennessee Department of Health this week, because I got a lot of comments on this one, made some protocols. It's basically if they set their protocol that you have sick people that need monoclonal, the ones the highest priority, sick people that are unvaccinated, which started howling, okay, in Tennessee, going, well, wait a minute. So the people that have rejected all of the science, rejected the vaccine, they get sick, they get the front of the line, while the same sick people, if they were vaccinated, they're second on the protocol. There's just going to be some interesting. Now, I don't know that anybody's run short in Tennessee.
Medicine has never been in that moral dimension to say you smoked, you don't get, you know, chemotherapy.
Yeah.
You know, it's a very dangerous slope to start making those value judgments on you deserve medical care, you don't deserve medical care. Because frankly, I'm not going to get my bypass because I've had way too many potato chips. So
you know, I mean, you're right. I don't know.
You can't do that.
Of doctors that have ever taken kind of the moral high ground. You know, you shouldn't be in the hospital because you do drugs or something like that. We treat patients. The other thing is, I'll say, and I've said this several times to my patients even, is there are no atheists in foxholes. Everybody who's got COVID all of a sudden wants everything out there that they can get for COVID. I've had a lot of people ask for vaccine in the hospital that have COVID. I mean, it's you know, all of a sudden they're all believers in the science, and our job is to treat patients sick. So, you know, when we started looking at kind of our protocols and everything like that, trying to find, you know, we started going back through the same risk factors we've gone through all the time, and we did not put vaccination on the list, and I stand by that. I agree with you, John. Or Scott. I mean, I can see where people can get a bit sanctimonious about it, but that's not medicine.
Hey, here's a fun question. Has anybody that's asking for monoclonal ever said to you, I don't know what's in that?
No, and I wouldn't be able to answer him because I don't know what's in it either.
Because
My guess is he's not had many requests for journal articles in the ICU either.
Hey, can I have one? But we're getting short of time. The discussion about the 5 to 11 shots is really ramped up this last week.
Yeah.
What do you?
It's
what
close.
do you think?
I heard it might go this week.
Yeah, I think we're going to get. I talked with my friend from ACIP that's on the ACIP board. He's thinking right around Halloween or just before that they'll get the first dose in. They're really they're getting leaned on pretty heavy by the pediatric AAP and other groups. Or parents are going nuts. Here we go.
Oh, parents are going nuts. I've had so many parents ask me to surreptitiously vaccinate their kid, and I'm like, no, we're not doing that. Yeah,
I think we'll I think we can really move it, and so I'm hoping by late October we'll have a first dose going. That's what I'm hearing.
Yeah, I heard today that Pfizer was really pushing them to take that under consideration, even as
and their data looks good from what I've heard.
And Catherine's asking a question here. If you have a breakthrough case and are symptomatic, how bad do your symptoms have to be to qualify for a monoclonal infusion? Catherine, the answer is monoclonal infusion candidacy isn't based at all on your symptoms, except for the fact that if your oxygen is running really low, it'll actually disqualify you. So the point here is, if you have risk factors for having worse disease, like the ones we talked about already, that's when you need to ask your doctor about whether or not you can get it. The earlier you get it, the better. By the time your symptoms are there, it may be too late. So if you are over the age of 65 and you get diagnosed with COVID, you need to be looking for your monoclonal as soon as you can.
All right. By the way, so before I want to ask about the OBI and antibody testing, I've had a lot of questions about that. So for you think that we're going to see by Halloween, you're going to see that happen, the EUA issued, and then is that going to be at Donnybrook?
I'm sorry, say that again.
Yeah, is that once the EUA is granted, is that going to be, are we going to see a rush on doctors' offices and who's going to be giving the shots?
I don't know.
I mean, I think what's the percentage of 12 to 17-year-olds? I think it's
still
that's less than 20, isn't it? Yeah. I can't imagine it's going to be much higher than that.
No, but there's definitely a group that are really anxious to go ahead.
No doubt about it.
Yeah.
All right, so antibody testing at OBI, I was giving the other day. I couldn't because of some antibiotics. I just found out when I went in. But so there's about to be a lot of things happening at OBI. And you know how many times I've heard people go, well, my antibodies are just great. I had them tested the other day. And I'm not really sure about the science on that. But what are you going to be doing at OBI?
Yeah, there's been a lot of requests. People wondered why we stopped doing the antibody screening in May. We thought we were coming to the end of COVID. We didn't know Delta, and we were in a big crowd of people who didn't know about Delta, so I won't say we were off base. But the demand for CCP, we had stockpiled enough, and that treatment has subsequently been almost entirely replaced by the monoclonals and other, the vaccinations have helped reduce the demand as well in terms of caseload. So we had turned off our testing, and coming back with a lot of folks want to know if they had the Delta virus because their variant. The request from the public seemed to still be there. We're short on blood, so we figured it worked last time to attract folks to understand what their personal status was. And the other thing that we think we can add a lot to the conversation on the state level about the exposures level. Now we test for the natural infection. Our test is for the capsid, the nucleocapsid, which is the shell of the virus. It's not for the spike protein, which is what you get from vaccination. So we figure that we have a lot to offer in terms of surveillance of the healthy, asymptomatic folks out there who aren't going to their physician, who aren't being tested. And this includes a lot of the high school population. We're fortunate to have a lot of high schoolers who give blood who there's not necessarily really great surveillance of what the rates of positivity are in those groups. So we figured we could probably add to the policymakers, data that they can look at in terms of where schools are. We could add to the general population where the whole public is in terms of natural immunization versus vaccinated rates. And then, certainly, hopefully this is a reason why somebody who wants to give blood and it needs just a little nudge to come in, they can understand something about their biology moving forward, because I do think down the road, there's going to be an interplay of vaccinated versus natural immunity come into the conversation. I don't think it's here now, but a lot of times the person will lose their antibody level over time and they will not know that they've had a previous infection. And so if the guideline becomes somewhat different for boosters, for example, like, okay, if you've had the natural infection, your boosters are once a year and not every 6 months or whatever that is. Just that extra bit of information could help in a very confusing, evolving set of guidelines and recommendations. So we figured that was good enough to go. And we started Monday, and we'll see if donors want this information and if it's helpful to public health officials. And hopefully we're making some decent calls here, and please come in and donate. Help us validate what we're doing and get better data and answer questions for individuals. Was that a cold you had 3 weeks ago, or
Right.
do you now have some broad spectrum natural immunity to add to your spike protein vaccinated immunity? Or if you're unvaccinated, at least you know what your status is. You still, the recommendation is still to get vaccinated. It's not an excuse not to get vaccinated, but it's a level of knowledge and comfort, and something to talk to your physicians about should you get ill.
I think he has some great information. By the way, doctors, Jennifer asked, any word on when the boosters from Moderna will be available? I saw the Moderna CEO on Bloomberg today talking about how good the numbers are, that they're getting close, but any idea when that's going to happen?
I haven't seen anything about it. I think the most fascinating information with Moderna is that it does look like it's a lot more protective against the Delta variant than Pfizer, and that the protection is more sustained from a lot of the studies that have been done. That being said, I think what you're seeing more than anything with Pfizer kind of being ahead of Moderna and all this stuff is the machinery of the regulatory department and the department at Pfizer that understands how to get things moved through the FDA to an EUA. Moderna is still a small company that doesn't have that big machine that is able to get all that data out there and know how to package it so that it's. But Moderna looks like a great vaccine. Now, Moderna. For immunocompromised patients, it can still be used as a booster. So that when we first talked about the solid organ transplant patients and everything like that, it can be used for a booster. But as far as a lot of those other groups, they haven't necessarily said exactly when that's going to be.
It was interesting to me that the data that came out about a week ago suggesting that the Moderna antibody levels were sustained much longer than the Pfizer antibody levels. That seemed to not get much press, but that to me would be, that was significant difference between
news.
The antibody levels.
Yeah.
Not that antibody levels are the be all and end all of immunity, but we didn't seem to have much of a discussion about leaning on the Moderna paradigm.
There's actually been some data even. So, what's most important data to us? The most important data is which vaccine keeps people out of the hospital.
Yeah.
And there is a little bit of data that showed that Moderna patients were a little less likely to be hospitalized. It was a small study. It's not a big deal. Again, these data take a long time to collect, a long time to package, a long time to review. But there was some, that's really the most important thing to me, right? It's those what we call primary endpoints and secondary endpoints. And so I don't really care what somebody's antibody level is. I care whether or not they end up in the hospital. And there's a little bit of data that shows that. So,
well, we should be, again, if you're talking about evolving our response, figuring out which is the better vaccine seems like it's a worthwhile activity for us. If we're investing all this time and asking people to get 2 shots, don't we want the best outcomes? I mean,
What about the dosage?
Air it out.
It's a higher
here-
dose.
Oh,
It's
sorry.
about 3 times higher. It's 100. But I mean, I don't know that the messenger RNA is exactly the same messenger RNA in both of them. The package that they put the messenger RNA in, the capsid, it's different for both of them. And I think that's kind of where the patent lies, is in that delivery mechanism. Because messenger RNA is just messenger RNA, right? You can't really patent that. But the dose is 100 micrograms versus 30 micrograms for the Pfizer.
That was a question I had on Moderna. And I'm not clear on it. Is the booster dose they're talking about is going to be reduced compared to the initial?
Yeah,
series?
they've been doing that study. They've been doing that study for Pfizer too. Whether or not it might just be a 50 microgram dose you're talking about, the 100 microgram that the primaries are. Yeah.
But that's not set.
That's not ready for prime time. But they're looking at lots of different scenarios.
Okay.
And Carl makes the really good point. Dosing interval may be important too. I think, when they look back at sort of the politics of all this stuff, the fact of the matter is they had to get these doses out there quick. And that's why a 3-week interval and a 4-week interval were done at the beginning. They couldn't wait 6 months between doses to do the studies. But it turns out that might be better. We don't know for sure. If one is protective enough, then it may behoove you not to just do it 3 weeks later. Maybe it's better to do it 2 months, 4 months, 6 months. I don't know. We don't know that yet.
Well, one of the things that makes me think that our regulatory structure, even though we were nimble with the EUA, I don't think the manufacturers are used to tweaking their formulas, which
Right.
in this case would have been appropriate, right? If just because you guess it's a 3-week versus a 4-week second dose, why are you locked into that in an evolving pandemic? Why aren't we running the optimization trials? We have enough people getting vaccinated. We could do those trials moving forward. It would be expensive, but if you get to a better vaccination regime, you're going to get a payoff in human lives.
Mm-hmm.
So again, mystifying, when you look at the questions, and you ask the next question in the pandemic story, you always hit these brick walls about, well, this seems to be something that would make sense that we should be doing. Oh, we haven't heard anything about that. I haven't heard a lot about optimizing the initial dosing schemes. And to me now, talking about it, I'm like, why wouldn't we be doing that? Why did we just take the first guess and whatever got through the FDA was good enough?
That's exactly why. You already said it right there. Because the company spends the money to get the drug FDA approved. Yeah. Anything else is going to have to come from federal grant funding, right? I mean, Pfizer is not going to pay to study 10 different dosing schedules. They got their dosing schedule through the FDA. They don't want to pay any money for that. I get it, but this is why generic drugs are never tested in randomized controlled studies, right? Because they're not going to pay for it. And so unless you have a federal grant paying for it, which I'm sure that they will. Eventually, and very well, maybe that somebody is. I can't say that somebody isn't, but it's not. You're right. It's not out there yet.
They should be talking about it, right?
Right.
If you're doing those studies now, that's part of the good news that we're getting better and better at the brainage that's going into our vaccine schedules. And if Moderna is slightly better than Pfizer at keeping people out of the ICU, that should be surfacing as a conversation about let's lean into Moderna and lean away from Pfizer. But again, these natural follow-up questions in this pandemic just seem to go off into cul-de-sacs, and it's frustrating.
Yeah.
Could I put up one more question before we get out of here? If the doctors take a look at it. This is from Leanne. I had a PCR COVID test this week, ended up being negative. I asked them if they wanted to know if I was vaccinated in case I had a breakthrough infection. The answer, no. If they don't have this information, how are they gathering accurate data on breakthrough infections? My son had a breakthrough and was tested at his college. They never asked him for that information either.
That's a great question. The state does look at breakthrough infections. If you're positive, they can go back and test the specimen to see whether or not you had Delta variant or whatever. They do molecular testing on it. I don't know. I'll be honest with you, with all of you, not just you, Leanne. I've always hated that term breakthrough infection just because it makes it sound like the vaccine's not working. What the vaccine is doing is keeping you out of the hospital. I'm glad you had a negative test. But The state is not tracking those necessarily regularly. They were at the very beginning tracking people who'd been vaccinated who had one, but that wasn't necessarily collected by the testing facility. It was submitted more by the lab after the test was positive. And remember, even though you got your test at a clinic, that may not have been that clinic that was doing the test. It may have gone to an offsite facility to get the test done. That offsite facility was who would submit it if they knew the vaccine was a breakthrough, the infection was in a vaccinated person, or more importantly, the physician, the patient's physician would also be expected to submit that information. And so they sent out a bunch of what they call OK Hans, which is a health advisory network memorandum about how exactly a practitioner or a lab could submit the data so that they could follow along whether or not someone had been vaccinated. Great question. Great question.
And one of the things I hope we do learn in this for the next pandemic, hopefully not in any of our lifetimes, but the whole infrastructure for public health, whether it's data gathering and reporting, analysis, contact tracing, very early on we were seeing how weak our system is to get ahead of the next pandemic. I hope in some of the government funding that's being proposed, and I haven't seen the details, and because of that, I won't say anything more than I hope we are addressing the fundamental weakness in a lot of our public health activities that we haven't invested in for many years, and we were caught short because of that. We can fix that.
Maybe we shouldn't move our lab in the middle of the pandemic either, though, John. I mean, some of them were self-inflicted wounds. But you're right. We have to go back and examine where we missed. You're absolutely right.
There's the last question I got.
Public health has always gotten the short end of the stick, right? There's so many examples of that. I mean, Dwight, particularly in the pediatric world, public health is always getting short in the stick because nobody makes any money off of it.
Getting adequate documentation, accurate documentation, particularly in terms of immunization, stuff like that, is a nightmare in the pediatric world.
We'll never have a better chance to advocate for it.
You're absolutely right.
Yeah. I mean, hopefully we'll never have another episode like this. And, I think when you look at the way we discovered the pandemic in the nursing home in Washington State, that's a heck of a way to run a surveillance system. And that wasn't the first cases. They've traced back, and they went back. It was here weeks before that doctor was smart enough to pick up on that cluster of cases. But that's a heck of a way to to let your nursing homes be your surveillance.
It's not a good canary.
Hey, last question. Well, I actually have two last questions. And number one, the one that I'm getting a couple of private messages on. Have we turned the corner? Are we on the way down?
Yeah, the trouble is it's a maze. There are lots of corners.
Yeah. Which corner?
Yeah, I mean, they had the article in the paper the other day that the 7-day rolling averages were going down. Does it feel like we're turning a corner a little bit? Yeah, it does. It does. And that's probably because of herd immunity and more people getting vaccinated. But by the same token, once you turn the corner, you can't let your foot off the gas. Now we're heading to the straightaway. We got this. Now it's more important than ever to double down on all those things. The reason this corner even came into play is because we didn't have enough vaccinations out there when we had that lull in the spring. And because we didn't have enough vaccinations, when there was a new variant around, it had dry kindling to go through. We have to make sure that all the wood is not available to be burned. And that is why we cannot let up, bringing this whole thing full circle. We cannot let up on making sure the people who are unvaccinated get vaccinated. That's more important than the boosters. It's more important than monoclonal antibodies. It's more important what the numbers are. The way out of this is vaccination.
That's the number one message right there. Yeah, just focus on that. Yeah.
The last question is for Dr. Armitage. I saw Costco has sent out information this week. They're going to limit toilet paper. Have you seen this? All right, what goes around comes around, right? So there's so many of these ships out here in LA Harbor they can't unload. So they're saying you're not going to get your Game Boy for Christmas. Are you going to be affected at all in the Nutter Butter peanut butter sandwich cookie? Any shortages looming for you?
Apparently, that catastrophe was narrowly avoided. From what I understand, we're back on track with our Nutter Butters, thank goodness. But
Are you a Nutter Butter guy?
In all fairness, we are facing a lot of unexpected shortages of supply. Our supply guys do a great job, but every week they tell us these kits are in short supply, and it's depressing that the supply chains. I know everybody's experienced this, and ruining Christmas without enough Game Boys is going to be terrible. But it sure has added an extra layer of frustration into this. And for us, when you can't do your job, whether it's employees or kits, I mean, it's just like fighting with one hand tied behind your back. You can't win for losing. So. Yeah. But no, the Nutter Butters are good, and if you come down and once you get over the antibiotics you're on, I'll slip you an extra one, maybe a chocolate covered one. If you've had those are amazing. The fudge covered Nutter Butters.
Very delicious.
I'm not a paid consultant for Nabisco, but I got to tell you.
The last point is I have to tell you, I've always wanted to be a member of Geek Squad. And Dr. Larry Bookman has advised me that he will fight any attempt by me to ever be a Geek Squad member. We've spent 45 minutes trying to get him on the air. And my wife just sent a message to me that I'm a dork, a tech dork. And so I'm fired from Geek Squad before I ever got there. So,
well, I should have never sent him that virus. I feel really bad about that.
Yeah, dang it.
So sorry. All right, Dr. Armitage, Dr. Chansolme, Dr. Sublett, thanks for being here. Thanks for all the questions tonight. I hope you got yours answered. We'll see you again next week. Dr. Bookman, wherever you are, we missed you. We'll try to get you back on. Whatever happened, we'll try to get Dr. Armitage's virus out of your computer. So, all right.
Have you seen the movie Tron? That's where Dr. Bookman is.
Wherever you are, orbiting in space, Dr. Bookman, be safe. It's out there with Elon Musk or something. Who knows? All right. Thanks again, everyone. Have a great evening.